Please note today's session is being recorded. If you have any objections, you may disconnect at this time. Thank you very much. And on behalf of the National Cancer Institute, I wish to welcome everyone to today's Implementation Science webinar. A brief word about logistics. We are excited to be joined by our speakers, and we ask that if you are not already on mute, to please keep your phone on mute for the duration of today's presentation. As mentioned, the session is being recorded, and muting all lines will help us to avoid any background noise. We encourage questions. They can be submitted by using the Q&A feature on the right-hand side of your screen. Type your question in the provided field and hit submit. Feel free to submit your questions at any time during today's call. And with that, I will turn it over to David.
Thank you very much, Sarah, and thanks to everyone for joining us. We're very excited about this session. Just wanted to mention that if you haven't attended previous implementation science webinars, or attended them recently anyway, just wanted to say that the way in which we deal with the format is we want to make this as much of a discussion as possible. As Sarah just said, we encourage as many questions as possible, and we want you to help us to drive the conversation. Second thing to notice is this is the first webinar upon which we're trying a new series, which is we've had a lot of great opportunities through the Cancer Moonshot to think about different ways in which we can advance implementation science. And so this is the first of a series where we're going to be learning about a number of the specific initiatives under Moonshot and discussing with you ways in which they might reflect on opportunities to advance the larger field. So we're very excited. And for one, implementation science, for those who weren't tracking this a few years ago, was one of 7 thematic areas that our Blue Ribbon panel decided was meriting specific consideration for what should the NCI do to advance cancer research. And out of that implementation science working group, we had a lot of great discussions, a lot of great initiative ideas. And then it came to those of us at NCI to figure out how do we take advantage of those and how do we make the most of the dollars that we got to try and advance the field. One of the earliest activities that we had once the Moonshot was sort of underway was a workshop that brought together a lot of folks to think through hereditary cancers and how do we use that workshop was on Lynch syndrome, but how do we use Lynch syndrome as a potential model for thinking about the population impact that we can have when we apply genetic testing to a broader population, when we think not just about individuals who have cancer, but the broader mix of the population that might have enhanced risk. What can we do to try and deal with that risk? What can we do to reduce it? What can we do to improve health and reduce the burden of cancer? So it seems fitting that the first entry into this sort of Moonshot series of implementation science webinars is this focus on hereditary cancers. And so I'm, as you can see from the slide, joined by 3 incredible colleagues, incredible experts, 2 of whom from the NCI, Erica Breslau and Nani Shelburne, who've really been leading our efforts in this area of how can we understand cascade screening, how do we understand broader implementation of genetic testing for hereditary cancers. And then Alana Ram from Geisinger, who has been one of our successful grantees, who's really trying to scale up genetic testing. And so we thought it would be a great chance to learn a little bit more about the initiative, to learn about each of their contributions and their thoughts about how did they get into this area. And then, again, as early as possible, you drive this, to inject your comments, your questions, that then Alana, Erica, and Nani can all give their perspectives on. So thought we would just start out and asking each of our panelists here to talk a little bit about how they first became interested in enhancing genetic testing in cancer. How did you get excited about this field, and how did you think particularly about the kinds of topics that we're focusing on here, hereditary cancers, and how we focus on implementation more broadly of testing and then of follow-up care. You'll see here periodically we'll change the visual. This reflects that we've done campfire chats, we've done fireside chats, sometimes we've just done fire chats. So here's a lovely set of wood and all of that. But with that as a lovely visual, want to ask Alana and then Erica and then Nani if each of you can just talk about how did you first become interested in this area? And so Alana, you have to go off mute, but otherwise we're good.
There we go. Am I off mute?
Perfect.
Okay. So yes, thank you, David. So how I became interested in this is a long time ago as a cancer genetic counselor. Of course, I've been interested in genetics and in cancer for a very long time. I became a genetic counselor back in the days when we first, basically BRCA1 and 2 had just been discovered. We were just starting to use it clinically. Cancer genetic counseling was just becoming a thing. And so we were just starting to do hereditary risk counseling. And then I had the awesome luck to start working with amazing behavioral scientists and folks doing this work in this space, everybody doing the early work of how do we communicate, how do we implement these programs, how do we help people use this information to really prevent disease, to prevent cancer. And then through the days of the early days, the first round of direct-to-consumer genetic testing, being involved in all of that, I've just been really lucky and still amazingly excited to be in the forefront of all of this. And I do have to say that Lynch syndrome workshop we were at is actually the day that this grant that I have was in review panel that day. So I also like to say I do what one of my mentors taught me, Russ Glasgow, who liked to use the Wayne Gretzky quote. I think I was skating where the puck was going to be. And I just like doing that.
Awesome. Well done you. So Erica, you want to jump in next?
Yeah, hi, I'm Erica Breslau. I started working in this area a long time ago when I was doing my undergraduate degree and trying to pay for tuition, and I was living in New Orleans. There were outbreaks of inherited syndromes, with actually colorectal cancer amongst the patients. So I went down and started doing very interesting family histories, and that then led to me working in cancer screening, which I've been doing at the NCI for about 20 years. And I recognized a decade ago that our program was not really addressing inherited syndromes, genetic screening, which was a very rapidly growing field, brought on by the well-known like the 23andMe, but we weren't doing anything seriously in HDRP, Healthcare Delivery Research Program. So I became very interested when Nona Kay approached me and Kathy approached me of how could we do this and look at how we could involve the healthcare delivery system, which was evolving just as rapidly as the testing is. So I recognize that it brought great opportunities. So that's it in a short nutshell.
Great, thanks, Erica. And that seems to lead directly into Nona Kay. Can you tell us a little bit about your entry point?
Happy to. I'm an oncology nurse practitioner by background and have always had a strong interest in understanding our healthcare workforce concerns and how we are using different disciplines to support the growing number of cancer patients and survivors. And so genetic counseling has been on my radar for many years as one that we know that the number of patients that need their services is growing, and the number of genetic counselors we have is not sustainable for what we need. And when I moved to the Epidemiology and Genomics Research Program at NCI, I became involved with the Lynch Syndrome Network and also Lee Fermani consortiums that we work with. And as the Moonshot really started phoning in on hereditary cancers, it was just a perfect match for me to be able to jump in and use my background to be able to support this initiative and really focus on how can we increase the ascertainment of cases, either with someone that knows they have cancer or even in populations before they get cancer, and how do we do the good follow-up care for these patients so that they're following these recommendations that we've seen come out in the last decade that say we need to be screening, but also we need to be supporting these patients and making sure that we're doing good follow-up care.
Great. So, which I think is a nice segue, because one of the things that we wanted to make sure is that the folks who are listening have a chance to learn about, two more specific things before we then jump into different questions. One of which is, about the specific initiative that you and Erica have worked on, and then of course to circle back to Alana and hear a little bit about the specific study that, as you mentioned, was being reviewed the day of the Lynch syndrome workshop, and of course is now in the field that you've been working on. So, Nanike, can you just give folks a sense of how the initiative was developed and sort of the current progress of it, and maybe Erica can chime in after that, and then we'll go to Alana and hear a little bit about her specific study.
So the Moonshot recommendation was in the area of cancer prevention, and they used Lynch syndrome really as this demonstration example, and wanted more demonstration projects of how we could increase case ascertainment and follow-up in these hereditary cancers, starting with Lynch, because we have these Tier 1 recommendations that have come out that we should be doing universal testing on all patients with colorectal, and we've seen some expansion into other cancers as well. So for the workshop, we used Lynch syndrome to really get an idea, but realized that it needs to be broader than that. So when we put out an RFA, we took the liberty to say that we were interested in all hereditary cancers, and actually we required all submittees to be looking at more than just colorectal cancer, more than just HBOC. And so we have applications that came in looking at multiple cancers. And they need to look at different strategies for how they would increase that case ascertainment and look at follow-up care and adherence to that. In addition to various strategies, because we know not one strategy will fit all areas of our country, all different populations, urban, rural, we needed these applications to look at their strategy within various populations, various healthcare settings. And so it was quite the challenge we put out, and we were excited to see that we had a large research base that took this challenge and submitted wonderful applications. And we also require that they be multi-investigator grants because they're large, and we really wanted all the expertise that we could on these. So we have funded 8 projects, 8 U01 grants through this RFA. There were actually 2, they were identical to each other. One just had a resubmission. And so those RFAs are done. Again, we have the 8 funded projects. Alana's R01 was also funded using Moonshot money before the RFA came out because it aligned so perfectly with what we were looking at. So technically 9. And I will say, Erica and I are excited that we continue to see independent R01s come in. Even after we finished the RFAs, really stimulated, I think, the ideas. And so we're seeing more applications come in, looking at different cancers, different settings, different strategies. And so excited to see the robust response.
Yeah, that's really awesome. Erica, anything you want to add on top of that? And I think we've lost your video, but we can still hear you, hopefully. Yeah.
Okay, I'll get it back then if you lost it. So that's one thing that I want to say about the healthcare delivery. Individuals, from the moment they enter the healthcare system, they face decisions, and it's regarding their risk management and how they communicate, how they and how various providers communicate with them. They're going to encounter genetic counselors, oncologists, primary care clinicians. And so one of the things that we're really interested in, some of the applications that I have, applying the risk management strategies throughout the healthcare delivery system. And this is a big thing that we requested that each of the UR1s be sustainable afterwards, so that we didn't just finish once the grant was finished. And that's something that we would like to see more of, which I think is going to influence some of your implementation questions later on, David.
Great, thanks. And so some of you may notice that in the chat, you'll see that we've already, Sarah's already populated a few links, and so you'll see a link to the Moonshot site. Love it if, as I'm looking at the Q&A box, love it if you have any follow-up questions just about the initiative or anything else. And you'll see also a link to Alana's grant, which we'd love to hear a little bit about. So Alana, you want to jump in and tell us a little bit about the grant? Oops, I think you're on mute still, sorry. Yeah.
Oh, okay, I have to wait for the beep apparently. Okay. So this grant, it started off really in collaboration with the Lynch Syndrome Screening Network, the Healthcare System Research Network, really leveraging all of these groups that I'd already been working with. And the goal is really to look from the back end, now that universal Lynch syndrome screening defined as the tumor testing, screening all colorectal and endometrial cancers for whether they may be related to Lynch syndrome, and then following up with genetic testing, germline genetic testing to confirm whether the patient has Lynch syndrome or not, and then contacting their family members. That being a universal Lynch syndrome screening program, the recommendation for that has been around for a little over 10 years now, actually over 10 years now. And we wanted to look at it from the other side, knowing we had healthcare systems that had tried to implement it and only gotten so far, ones that had seemed to be doing a really good job. My own healthcare system, Geisinger, when I got here, I worked really closely with our pathologist to optimize and improve our program. And, as we're discussing and presenting that work with our other colleagues in the Healthcare System Research Network, we had groups that hadn't been able to implement it. It really just became the opportunity to understand from this standpoint, rather than trying to facilitate implementation, understand it from the back end of the stakeholders. What is it in those contexts that they're dealing with, even though every single organization is different and may be dealing with a different constellation of facilitators and barriers? There's got to be consistent solutions to those facilitators and barriers, and how can we determine those and tease those out and put those together in a way that can help organizational decision makers really figure out how to improve their programs and improve them to make them work, and improve them as transform them as evidence changes. And how can we make this, can this be even a model for beyond Lynch syndrome, so for other hereditary cancer programs as well? And so our goal is really to develop a toolkit or a set of tools to help with that process, to say, if here are the barriers and facilitators you're dealing with, here are those solutions that might work for you, and how to put those together so that you can actually do this and see benefit from your programs to identify and facilitate genetic testing to identify individuals with hereditary cancer. In our case, specific case, Lynch syndrome. But again, using it as a use case.
Great, thanks so much. And again, as you'll see in the chat, Alana has been gracious in allowing the entire text of her grant basically to be posted, so that others who are interested in how she framed the study are able to learn from it. So Alana, thanks in addition, for your doing your work to sharing it so widely with folks. So we did want to get each of your takes, and maybe we can start with Alana and then go to Nanike and then Erica. Just where do you, if you have your crystal ball and you're trying to chart, how do we continue to make progress? There's certainly a ton of interest and investment in precision medicine broadly, in genetic testing and, hereditary cancers. And, there's always that concern of, we get these great discoveries, but they never actually impact the broader population. They never have that benefit that we'd like to see. With your various, prognostication powers, where do you see the field progressing in the future? Where would you like to see the field go? Alana, you want to start us off with that?
Okay, do I need to wait for the beep?
No, you're good.
Okay, this time it didn't make me do that. I'd like to give the answer. Of course, everybody's going to have their genetic sequence at birth, but, I'm not actually going to go there. I think where we're going is, at this point, it's going to take a number of different programs. There is no one magic bullet. It is universal Lynch syndrome screening. It is testing all newly diagnosed ovarian cancer patients. It's testing newly diagnosed cancer patients in general. It's family cascade screening. It's population screening of, population sequencing programs, working with, people who've had their genetic testing done through direct-to-consumer companies and are asking questions. It's all of those things. It's engaging them where we can get them to engage with this information. So that's where I kind of see this going, and where I think, again, implementation science just fits perfectly with all of that, because we can be sort of agnostic as to which program and still work with how do you implement that and how can you use that to get to your population.
Great, thanks. Nanike, you want to, same question for you?
Yeah, I agree with everything Alana said, and I agree that it's going to take scientists working within their area, within their population, within their culture of where they live and where they're doing their science to find out what works best for these different areas across the U.S. And the one place that, that there's definitely growing interest, but there's an enormous amount of ethical hurdles, is how can we do childhood testing? How can we use neonatal blood spots? We're seeing the increased use of those for different inherited traits, and right now the concern is, would you use that blood spot to identify something that wouldn't affect the child till they're an adult? So there's a focus on, can we at least use those for things that would affect the child during childhood, adolescence? But, we're just I think we're gonna have a growing discussions about how we use that to our advantage to benefit our patients, but keeping ethics in mind.
Great, and Erica, you want to?
Yeah, I kind of agree with Nanike and Alana that ideally I envision a greater collaboration of the field so that these issues are dealt with, so that as we do come up with the development of new and more precise tools, that it's not going to be a shock to one population and not another population, so that there's more spreading of the wealth, so to speak. So that's about all I have to add with that.
Okay, well, thanks for that. And just wanted to give a reminder to folks who haven't yet started to type out the questions on your keyboard. Let us know what questions come to mind. We'd love to engage and just see what you're thinking. How can we help to support toward the next steps that each of our panelists have at least aspired to getting to. And I think along that note, and you'll notice here a slight change, is that's fire and water together, Sarah?
Yeah, fire and water together. I actually wanted, do one more quick note, because we've had about 15 or 20 more people join since my initial pitch, which is you can ask questions at any time during this session. You want to go ahead and type those in the Q&A field or the chat to me, and we will get them and pose them to our speakers. So as that reminder, go ahead and type it in the provided field and hit submit. Thank you.
Yes, thanks, Sarah, for that. And I think one of the things that we've at times struggled with is gauging what is the capacity of the field to respond to some of these really important questions of how we get effective genetic testing, follow-up care for hereditary cancers as broadly implemented and sustained as possible. So the next question for our panelists, and maybe we can start with Erica and then Nanike and then Alana, is to what degree do you see, just from your gauge of the field, to what degree do you see the need to still build capacity to advance the field? Do we need more people engaged, or what kinds of activities would you see necessary to recruit more folks to the effort?
Okay, that's a great question, David. There's a couple of areas. One is improving health equity by addressing the underrepresentation of diverse populations in genomic research. There was a really nice paper that came out in 2019 by Sona Juma just on this topic, where she talked about how to accomplish this, we need to deploy diverse workforce individuals into the various settings. We need to have better infrastructure support outside the traditional research centers or cancer centers. And we need to really actively work with the ways that we know how to reach engaging communities and healthcare providers. And And another thing, I would say that there's a gap, whereas we're very slow in applying knowledge. And one of the areas, this is my second point, is that we can do studies now that show that it's continuing care. For example, there are efforts underway with the learning healthcare systems, and that means that healthcare systems that undergo a continuous improvement through data capture, they're able to leverage healthcare improvements. And this is a strategy that's very promising, particularly as we consider how do we reach out to underserved populations.
Great, thanks. Nanike, your thoughts about capacity building?
I think Erica mentioned this earlier, but it really is collaborative science. And one thing that the pandemic has highlighted is the need for telehealth expansion. And we've seen that some of the barriers we've seen with genetic counseling around hereditary cancers and others has been around, inability to reach over state lines. And some of those barriers have been pulled down with the pandemic. Will they stay down? Are they going to be barriers that we have to address again? But I think bringing in telehealth into some of these collaborative groups would be a great capacity. I, being a nurse, am very interested in nurse scientists joining this group. I think nurse scientists bring a lot, not only to implementation science, but hereditary cancers, working within these clinics, working within these populations to see what other strategies we can improve. And I think one of the largest capacities has got to be public awareness. This is something that's out there that many people live with. They don't know about it. Some don't want to know about it, which we learn when we start doing genetic counseling to decide if people want to be tested. But there needs to be a public awareness that this risk is out there. And if we do identify patients positive, that there are things we can do to assist them to hopefully have improved outcomes.
Great. Alana, your thoughts? And again, we're on mute, so we got to undo it.
Oh, there's the beep. Okay. I have a delay. So to build on everything that Erica and Nanike just said, I would agree with everything completely. I think some of the big opportunities are within our learning healthcare systems, our healthcare systems in general, and just maintaining that engagement, working so closely with the clinical enterprise as well as our communities. It becomes important in our rural communities and all of our communities, regardless of where they are and who they are. Just that engagement of the clinicians and the individuals is so critically important because of the needs with not only to get to the initial individual who's doing the genetic testing or being identified with the hereditary cancer, but then their family members, and how do we engage families and facilitate that type of communication. And I would say a huge, just like Nanike, to be a little self-serving on my background as well, is the genetic counselors. These are people who are on the ground. We're used to the plane being built around us while it's flying, right? Genetics has been changing over the last 40 years of the field that it's been around. And so we're on the ground implementing these things, trying to figure out how to implement these programs from the get-go. So I think the genetic counselors are terrific partners in helping us figure out how else do we do this? How do we improve that capacity? There's not enough of us, but if we change the models, how can we do it differently and be effective? We know how to communicate with the family members to engage them. How can we use them and bring them into this fold? Same thing with our folks in the public health realm, our program folks who are in our state cancer programs. Some of the states have amazing programs. They work in the newborn screening areas. All of this, they're huge. I think untapped resources.
And Erica, if I can jump in, we have several requests for the paper. I did not catch it fast enough. Could you mention the author again, and I'll pull it off of PubMed for our attendees? And you were on mute, so I'm sure that you are saying it.
Why don't I send you the link afterwards, okay?
Okay, thanks, Erica.
Okay, thanks. Yeah, and appreciate the questions that are starting to come in. So without further ado, want to get to the first question, which I think I'll start with Erica and Nanike, if one of the two of you want to start, and if there's anything that I can do to answer as well. So the question asks, do you anticipate more Cancer Moonshot opportunities, specifically around cancer genetics? Anything, Nanike or Erica, you want to say about that? Or do you want me to?
The Moonshot Initiative was funded for 5 years, and we are finishing that up going into FY, or I think into the next year, or starting to wind down. So I don't foresee any new initiatives coming out from Moonshot particularly, but as I mentioned earlier, we are excited to see investigator-initiated grants still coming in, addressing many of these areas, and it remains an area of interest. And Erica and I are always happy and available to speak to anyone that has a project that you're considering and helping you to figure out how to get these in the system. I will say that NIH just renewed the funding announcements around ethical, legal, and societal implications in genomics as one potential funding announcement that does take these type of applications, and there's others that we can direct you to. So please contact Erica and I.
Great. Erica, anything you want to add on that? Or? Okay.
And I think you may have more insight than I do. I mean, it's just like echo what Nanike said about us winding down.
Yeah. So for folks who have been watching, when the Moonshot was initially constructed, and there was it was part of the 21st Century Cures Act, and there was a set expected amount of appropriations that would happen each year, and so it was very much front-loaded. And so what that meant was that if you envision, and I think the broadest thing was 7 years, but what it meant was that if you have 5-year projects, it's really only the first few years of it that you can initiate the projects, and then a lot of the later dollars go to the subsequent years of projects that were initiated earlier on. But just echoing what both Nanike and Erica have said, I think often our initiatives indicate a broader interest because we know within any one announcement, we can only get a certain amount of activity underway. And as we've seen, some of those applications that might have started as Moonshot or started as RFA applications, because they remain of interest more broadly to the field and to the Institute, come back in as investigator initiated. And certainly this is an area that I think we, from all points would say that there's a longer line of work needed to be done than what we're able to accomplish just through a couple of different RFAs. So yeah, thanks for that question. You'll see now in the chat that the specific paper that Erica had mentioned before should be there. Another, I think it's a related question, and I'll take it because it relates to sort of the implementation science group at NCI, which I am fortunate to be a part of, asks about how warm or how receptive we are to studies that are focusing on identifying and addressing disparities in hereditary risk genetics. Certainly turn it over to Erica and Nanike for their thoughts on this. But for our team, I mean, I think both in the Moonshot, but also in our underlying sense of implementation science and how it can make an impact is very much tied into how do we do our best to not just reduce, but eliminate disparities in access and the quality of care that we're receiving and the outcomes. And so we would be continually receptive to ways in which our evidence base gets applied to maximal benefit of all populations, and particularly focusing on those who we can do even better than we've historically done with. So I would love to see your thoughts about how we can reduce and eliminate disparities in this area, as well as more broadly for implementation science overall. But curious, Nanike or Erica, just on the question of disparities, the degree to which in your various portfolios, you also see the opportunities. Anything there?
I will just start by saying this is an understudied area. I'm not going to say it's a gap, but I would just say that we need to do a lot more work in this area, not only looking at the different populations, and I don't just mean African American. We have very large immigrant populations here that come from very diverse backgrounds that we know very little about. And we know very little about how to reach these populations. Some of the traditional modalities would work, but we have a lot more work to do both with our outreach as well as reaching these individuals. No more to add there. Kate?
And this is the reason this was part of the RFA as well, is that the applications had to address multiple populations and really reach out, not to just those going to academic centers, not just those in large health plan insurance type-based care settings. And so we did see that our projects began to reach out to populations that were not currently being targeted, but there is a lot of room for growth. And so I think that we can continue to see that through different mechanisms, whether it be administrative supplements to current applications, but also looking to these investigator-initiated applications.
Yeah, great. Thanks so much for that. And thanks for these great questions, which I see are now populating our sort of inbox, so to speak. So do want to get to that. And maybe a question, I'll see if Alana wants to start with this. And this question, I think, again, is on a similar theme around disparities and says, I'll just read it. In the underserved Latina population, we are increasingly seeing women get tested without having genetic counseling because it is harder to cover counseling than it is to cover testing. Women often do not get enough information about the results and implications. What are your thoughts about how implementation science can help address this challenge?
Yes, so that's an excellent question, and there's a lot of work on the what we sort of call the flipped model of genetic counseling. We've for many years we've operated under this idea of we have the genetic counseling first, so that you understand what it is you're testing for, and making sure that we have this whole shared decision-making conversation, so you understand the risks and benefits of what this information is that you're going to get, and before we actually do the test and give you that information. And there's been a lot of work from some excellent colleagues in anthropology and other areas, in these different populations, Latino populations, other populations, about the difficulty in communicating, and when we're doing these genetic counseling sessions, whether that really is salient, whether that's information that makes sense at that point in time, or whether people actually understand this information better if they have a result of some sort or the test first. And so I think, there's your standard trials that can test those sort of ideas. Implementation science can certainly help us if we are already looking at those different models. You can test them against each other and for outcomes in different populations. I think there's just a lot of work to be done in this area, and it's certainly a consideration as well, because the understanding of when your test is negative, you need to understand a different way than when your test is positive, and it depends on if you actually have cancer already or not, and there's all sorts of things to understand. So how do we really help people understand that information, rather than thinking from the standpoint of if you have to have it right at the beginning before the test, but where is the best place to get it? And for different populations, for Latinas in safety net settings, it might be in a different point in time where it's both feasible and makes sense for the healthcare system, but also feasible for the person to use the information, versus Latinos who are in, say, have access through a healthcare system. It could be a system level issue of where it goes, and it could be for the importance of engaging our communities to understand where do you need this information.
Yeah, thanks so much for that, Alana. And just a note that Sarah just put to all participants a recently related RFA, thanks to Leah Mechanic in our division for pointing that out to us in real time, which has the title, if you haven't gone to it, that says Investigator-Initiated Research on Genetic Counseling Processes and Practices. And specifically, as I was scanning through the RFA a second ago, just talks about how it's very much trying to overcome issues of unequal access and disparities. So definitely take a look at that one, which our colleagues at NHGRI, along with NCI, are involved in. And what's funny about that is it's a beautiful segue to one of the other questions that was asked, and I'll see if anyone else wants to chime in on this, and that's how are NCI and NHGRI working together, dividing up content areas within this area of screening for hereditary cancer. So I wonder, Nanike and then Erica, do either of you want to chime in on sort of NHGRI and NCI connections?
We've had connections at multiple levels across different initiatives. For Moonshot, just the way that the funding happened, it was based within NCI. But as Leah mentioned, this RFA on genetic counseling is something that came out that we, NHGRI, pulled in NCI from an oncology standpoint, and we were able to work together and make sure we had good input. There's other collaborations around genetic competency of our professional colleagues that NCI has been involved with, that NHGRI is leading. And so there's a long-standing collaboration around the All of Us study as well. And so, you know, it really is strong, and we continue to move forward. We don't currently have anything in the works for around hereditary cancer specifically, but it's definitely ingrained in multiple RFAs and initiatives that are ongoing.
Great. Erica, anything you want to add to that?
Yes, I'll just say that we have had strong collaborations in the past dealing with communication. How do we communicate these testing to primary care clinicians who seem to have a big gap in and confidence in being able to deal with integrating this into their practice. But as Nanike said, we don't have anything active right now.
Okay, great. Thanks so much. And again, love the questions coming in. So we're trying to be mindful of the time to get to as many as we can. Just so, you know, again, we're trying to make sure that we, you know, transmit all the links that have been discussed. So keep looking in the chat, and hopefully you'll see some of those links. I know that was another question that popped up. Next question was just, and maybe I'll appreciate the question and try and reframe it maybe a little bit more open. So it talks about how the Moonshot is in the process of building capacity, and obviously any limited number, or even 9 projects, cannot address all the barriers to implementation. You know, to what degree would either administrative supplements, or I think as was discussed before, you know, ancillary studies be of interest to try and build more capacity? So just wonder if, again, I think this is probably more for Nanike and Erica, how do you think about whether it's administrative supplements that are trying to expand a particular study versus an ancillary study that would add? Any thoughts there?
There are absolutely opportunities for administrative supplements across our funded grants, whether through Moonshot or investigator-initiated, and we have seen those come through, and we have been able to fund some to expand either what's going on in those projects, or we've had projects that have identified a specific issue, such as one identified that whenever they were trying to pull family history from the electronic health record, that in the Latina population, it was specifically underrepresented having a complete family history. So trying to delve in and try to figure out why that is and what we could do to fix that. And then within Moonshot, you know, Erica and I continue to have conversations about, you know, what ability we still have in Moonshot with any funds that are left to do other supplements as well.
Great.
And that was a nice summary, Nanike. And I would just say that please continue to reach out to us if you have ideas. We're very open. You know, if the time is not right at the moment, We certainly have a big file where we collect this and discuss opportunities that we may hear about, where we can either issue a general supplement request or specifically to come back to you.
Great. Thanks so much for that. A question that would be great to get Alana's take on, because, you know, as a genetic counselor, knowing the landscape, the representation among the community of genetic counselors, one of the questions was basically, can you comment on, is there a lack of diversity among genetic counselors and how that might affect disparities? Any thoughts just from the perspective of the profession of genetic counselors? Oops, I think you're on mute. Yeah.
I gotta wait for that beep. Okay. Yes, it's been something we've been wrestling with in the profession for quite a long time. And we're, as a whole, the National Society of Genetic Counselors, we're consistently have efforts to improve not only our reach, but improve getting diverse representation within the field itself.
Okay, so it sounds like it's on the radar, but progress needs to be made. And I think, yeah, okay. Thank you for that.
Always more progress could be made.
Yeah. No,
I will say that there's also been work looking at even lay navigators, lay genetic navigators, trying to get people from the community that look and represent the culture and the ethical backgrounds of those they're trying to reach, and trying to use them as a stopgap, a facilitator of getting them to genetic counselors. But I think there's a lot of work that needs to be done around the feasibility of that, the cost of that, and the success.
Great. Oops, and I think Alana, I don't know if you had something to say on mute again, but no. So thanks for those, and really thanks so much for the question. There is another question that again might be, often it's about training mechanisms, and often our training mechanisms at the NCI are generally run by a specific center for cancer training, but would love to know, Nanike or Erica, if you have any insights on this, or maybe then Alana from the perspective of just genetic counselors and knowing different career development opportunities. But the question asks, would the NCI consider establishing K or career awards for master's level genetic counselors? So curious about training mechanisms that are open to clinicians, master's level genetic counselors in this case, who are interested in advancing the research skills. Any thoughts there?
Well, we don't, our division, our area doesn't specifically do the training grants. There's an office that does training grants. That would be the most appropriate place to go. But I would say, though, for early or mid-stage investigators, reach out to some of our inherited syndrome investigators and see what opportunities they may have. And Alana is a big example. Monica, do you have anything else to add on that? Yeah.
No, I think you covered it.
Yeah, and sorry, Alana, you want to jump in, please? On mute.
Wait for the beep. Okay, I want to add. So we'll plug the TIDRC, the Training and Dissemination and Implementation Research in Cancer, is now open, recognizing that master's trained genetic counselor, that is their terminal degree. For a lot of genetic counselors, there's some of us who've gone on to get magic letters, but it is the terminal degree in the field. And so they are now, as far as I know, that hasn't changed, that they're allowed, that they can apply for the TIDRC training. We've had 2 so far that have gone through. So that is an open thing. And there was recently, I don't know, Sarah, if you can find it, but I know there was a call, an RFA out for supplements that were led by genetic counselors. So supplements to existing grants that could be led by genetic counselors. And I would frankly love to see more of that.
Yeah, and just to further along what Alana was saying, we have absolutely had fellows in the TIDRC training programs who are master's level genetic counselors, because we've modified at one point when originally the TIDER training, the Training Institute for Dissemination, Implementation, Research in Health, was developed, there was a criterion that said sort of doctoral level degree, which included, you know, in MD. And then what was recognized was, well, look, I mean, when we were thinking about MDs, it wasn't necessarily the doctorate letter, it was that it was at a particular clinical degree. And so that was why we wanted to make sure it was broad, so that if the you know, key clinical degree in another area, like genetic counseling, is a master's, that would be great. And so that's definitely been the track that we've been on the last few years. The other thing is that TIDERC is, of course, now open access. So anybody who doesn't have the ability to, you know, apply for the specific course when we have it as a moderated thing and a mentored thing, can definitely have all access to the materials whenever you want, and that's on our website as well. So we do have, there's sort of one more question that I wanted to get to. Sarah, does that sound good? And then we'll, okay, great. So the final question is actually a sort of, you know, I think, where are we going, or that sort of, what do you see as the next frontier of research in the area? So just wanted to give each of you a chance, maybe that final, as you see this final picture of a fire, that final chance to say, project forward, what do you see as the frontier? Where do we need to get to, or where would you like to see us get to? Alana, do you want to start? And then maybe we'll go Erica and finish off with Nanike.
Okay. All right. Okay, I don't have to wait for the beep. Wow, give me the hard question first. Where do I see this going? I really think we're heading towards looking at this, really the multi-level thinking, and involving our communities, our clinicians, the primary care providers, the specialists, everybody on the ground, trying to do this together, as well as the researchers and across multiple systems, and just understanding, while we all of our contexts, while we're all different, dealing with our individual families, the state issues, the healthcare issues, understanding the common solutions that can work within those constellations of barriers, and those things that those facilitators that we can leverage regardless of the context that they're happening in.
Great. Erica?
Well, of course, I have to pick up on the concept of multi-level. That was my inherent trigger to expand on what you said. One of the things is that a limiting factor that we have had is incentivizing clinicians and encouraging them to partner with different ways of doing business. And this involving the healthcare system leaders themselves, and then at the other end, the community. And we talked about using patient navigators who look like the people they're reaching. And, you know, this is a big country, and COVID has given us an opportunity to do new models of care. And we're starting to see this with telemedicine, which was far more common in rural communities. And I think it's now expanding, from what I'm hearing with some of my grantees, to diverse racial and ethnic groups. And we have an opportunity to bring up our game and to make changes that we haven't had previously. So I'm feeling very optimistic about going forward, that COVID has provided opportunities for us to work at different levels, and that there's an opening and an opportunity.
Great, thanks. Nanike?
I think there's multiple ways that people are learning about their genetics these days, you know, whether it be through a provider, whether it be through direct-to-consumer testing, whether it be that they signed up for the All of Us research protocol. And, you know, it's good that we're having this type of projects funded in this research, because I think we're streamlining that as people find out things about themselves that they weren't expecting. They had a 23andMe test done for fun, but suddenly they find out that they carry a BRCA gene. and suddenly changes their life, that we've got these strategies for communication. We have strategies for getting genetic test counseling and confirmation testing done. And so I feel like we're on the right path, and we're kind of tracking with, hopefully, with the amount of genetic information people are finding out about themselves, that we're finding these strategies to say, okay, from the cancer side of things, this is what we need to do. This is the follow-up care. This is how we talk to your families, how we get cascade testing, and overcome many of the barriers that are out there. So as we continue to find more validation studies of what these variants and SNPs mean, that we are able to provide context to these patients on what it means to their lives.
Yeah, thanks so much to all of you for those comments, as well as the three of you for all the comments that you've made. Thanks so much to everybody for the questions that you've asked. I mean, I think, you know, from what I've heard, and certainly the enthusiasm of this group in doing better to improve equity, as you know, various questions and your comments reflected that as a diverse country, and recognizing disparities in access and recognizing underrepresentation within different different professional groups, there's a lot that we can do. The other thing that seems so great about having more and more work in this area is that it does reflect how fast the field is moving, how fast research is moving. And if we get away from this idea that evidence is created, it's fixed, and then it's implemented through to much more of this dynamic back and forth between the communities that we work with and we're seeking to support, clinicians and everyone else who's trying to provide care, and the researchers who are trying to figure out what are the right questions to ask, that precision medicine and implementation, or genetic testing and implementation, seem to be a really nice model for this larger complexity that we often don't think about when we sort of reduce everything to a single intervention for everybody. So thanks so much. I'm going to turn it over to Sarah to close us out, but really wonderful questions, and feel free to follow up with us if you have any more.
Thanks so much, David. And I also would echo my thanks to Nanike, Erica, Alana, and David for this wonderful session, and to all of you for such great questions. We hope that you join us in September after our brief hiatus for another Moonshot webinar on symptom management. An archive of today's session will be available on our website in about 2 weeks, and we hope to see you soon. Thank you again for joining us. You may disconnect at this time.